Good evening, everybody. Thanks for coming. I'm John Ralston. I'm the CEO of the Nevada Independent. First things first, is this a beautiful property and a beautiful room or not? Yes, clap for that. I want to thank Maurice Wooden and Stacy Michaels of the Fontainebleau for being our partners in this. We have found the Fontainebleau to be just a great partner for these events, and we're really thrilled to be able to put on an event with the kind of quality panel that we have here and to try to illuminate difficult issues, including this one. And we also couldn't put on these IndyTalks without our sponsors. Let me just thank them up front. The Raiders, HCA Healthcare, Southwest Gas, Nevada HealthLink, Pharma, and the Nevada Donor Network. Let's have a round of applause for our sponsors. You know, we started the Independent, we call it the Indy, a little more than 8 years ago as a leap of faith with a small group of folks huddled around the kitchen table in Carson City on January 17th, 2017. We believed then, and I believe today, with our staff having tripled since we started a little more than 8 years ago, that there's a yearning out there to cut through the partisan cacophony and provide deeply reported information to help people make sense of a chaotic world. It's been a roller coaster, I have to tell you. And we've surmounted some tough times, but I wouldn't trade these last 8 years for anything. I'm so lucky to have worked with some wonderful, dedicated, and talented team members. They make me proud every day. They are the heart of the Nevada Independent and why we've been so successful for a little more than 8 years. We've achieved a lot, but we can achieve a lot more with your help. If you're a regular donor to the Indy, raise your hand. I love all of you. The rest of you, So thank you for that. If you're not yet, and you appreciate what we do and appreciate this panel tonight, please consider giving us a recurring monthly donation. That's how we get more along the path to sustainability in the long run. So thanks to all of you for coming tonight. Give yourself a round of applause because this is an important issue. So now on to the program. Please remember that we want these discussions, and that's what they are, discussions, conversations, to be civil. So no outbursts or boos or anything like that. We appreciate that. It's one of the things that we strive for at the Indy is to elevate the discussion. So let me introduce the person who's going to lead this discussion tonight. And I couldn't be prouder of Tabitha Mueller, who has, from the very first moment that she came to the Indy, distinguished herself with her passion and her work ethic and her dedication to the culture of the Indy, which is to try to provide deep and unbiased, fair reporting. Tabitha is one of the true stars of the Indy, and she's going to be a star into the future, and she's only 14 years old, which is also amazing. But seriously, please welcome Tabitha Mueller, and she's going to introduce the panel.
Thank you so much for coming tonight. I am incredibly excited to have this panel. We have some fantastic experts, and I'm going to introduce them starting with Pat Kelly here. Pat Kelly is the CEO and president of the Nevada Hospital Association. Next to him is Mike Wilden, who has spent more than 45 years in state government. Specifically, he led the Department of Health and Human Services for a long time and was also former Republican Governor Brian Sandoval's chief of staff. And then next to him is Stacy Weeks. She's the director, or the Nevada Medicaid Administrator. So please give them a warm welcome. Thank you for coming. It's not always easy to come up and sit on stage and be grilled by two journalists. So I think that first off, where I want to start is a topic of conversation that we've heard across the country and here in Nevada, Medicaid cuts. Now, recently we've heard, as discussions have happened at the federal government, about possible cuts to Medicaid that could potentially leave Nevada $1.9 billion but short on our budget, as well as potentially lead to the loss of 312,000 people on Medicaid currently. And the basic proposal of this is that they would cut what's called Medicaid expansion. And under Medicaid expansion, low-income people were included. So I kind of wanted to start with that and just see how would it affect each one of you and the entities that you work for. start with Pat Kelly over here.
Well, Tabitha, Mike and I are gentlemen. We already made an agreement that we'd let Stacy's take all questions first. But no, it actually has a big impact. And what I'd really like the audience to know is that Medicaid cuts, believe it or not, have a huge impact on you because it affects hospital rates and the rates charged by other providers. So there's a big cost shift in this state. And so when Medicaid goes down, the costs have to get shifted off to somebody else. To give you an idea, we have 2 programs for Medicaid rates for hospitals. One's a base rate and one's a supplemental payment. On the base rate, we basically get 53 cents of our actual cost, and then the rest is shifted somewhere else. And so that's a huge deal. Now we passed and to give you an idea, over the last 22 years, hospitals on their base rate have got a 5% increase. Now, how many of you in your businesses have only had a 5% increase in your revenues? I'm guessing there aren't too many. And so during that time period, the 5%, we've also had 71% increase in costs. So this shift gets even bigger. So that prompted us to do a provider fee program, and that's a supplemental payment program. So we got that up and we got it running, and as soon as we did, everything started to happen in Washington, D.C., and it kind of slowed us down. So any cut has a huge impact on hospitals, and it also has a huge impact on all of you.
And when you're saying that huge impact, does that mean we have fewer providers? Does that mean that there's less money for services? Maybe, Mike, would you be able to kind of break that down for us?
Yeah, weigh in a little bit here. Healthcare isn't just about healthcare, the system of healthcare, but how you finance the healthcare system. And so, I think the 2 big things that we're worried about, I guess, for lack of better words, 2 things. Part of the Medicaid population gets a 90% federal match on the cost of care. And so that's the question. If that 90% match is taken away and goes down to what we call the basic match, which is a 60% match, then I'll just simplify it. For every $1 million worth of expenditures, now the state has to put in 100,000, the feds puts in 900,000. If it changes, the state has to put in 400,000 and only get 600,000 from the feds. It's a quadrupling of the state's share of the cost. So it's a big deal. And financing healthcare has always been a challenge in Nevada. Finding the general fund dollars, when we all talk some more here, it's a struggle to find state general fund dollars. And so we do things like Pat just talked about. You find other sources of revenue. We, do provider taxes. We ask the counties to contribute. We do intergovernmental transfers. We find every tool we can to create the non-federal share. And it's a lot of money.
Do you want to jump in there, Stacey, and kind of talk about it from the Medicaid side of it?
Yeah, I mean, I think everything everyone's already said is really important to access, coverage. I think, beyond just the actual impact to the people in the state and to providers, it's going to be an impact to the whole state budget. There's no way to come up with $1 billion without taking it from Medicaid and from some other pots in the pie, right? You're going to have to pick other pockets. So we're talking education, transportation, all areas that I would argue, are not always fully funded either, right? So if we're not making new revenue in the state, we're going to have to reduce sort of spending overall, which is, I think, part of the conversation people are not talking about yet.
And one of the things that I kind of think about is the role that Medicaid plays. And I'm wondering, can we take a step back for a minute and just talk about Medicaid's place in the healthcare landscape and in Nevada's landscape as a whole, right? Even if I'm not on Medicaid, does that affect me?
Mm-hmm. Yeah, so I'll take this one, guys. Ladies first this time, Pat. No, I would say, Medicaid covers 1 in 4 Nevadans in the state. So if you take away coverage for 25% of the population, providers aren't getting paid. They're not going to be able to keep their doors open. I think we're going to see other smaller clinics and hospitals struggle to make ends meet. I mean, Medicaid is a $15 billion, $16 billion program over the last biennium. If we lose that money, it does affect the whole healthcare system. Even if it's a portion of that money, it's a lot of money for the state.
Can I jump in here
Yeah.
real quickly? And Stacy, by the way, I'm going to call you now the state's pickpocket, since apparently you're going to pick all the other pockets in the state budget. But seriously, there's two impacts here. One is on the people who are served, the 800,000 or so people, and then there's the providers on the other side, as you mentioned, if there are cuts, who can be shut down. I'm wondering, and Stacy, have you had conversations with the governor or other people about what the contingency plans might be if this happens? Because nobody in this room, nobody on this stage knows what's going to happen, right? And so it's hard to plan ahead. The uncertainty is really difficult. So tell us about some of those conversations that are going on.
Well, I haven't talked personally to the governor since he called me a unicorn on your last show. No, I'm kidding. But no, in seriousness, there are a lot of conversations going on between my office and the governor's office about these impacts. We are trying to think ahead, but we are in the middle of our legislative session, which is a steady drumbeat. We have very little time to breathe between each day, trying to keep the program running, do 75 fiscal notes, and answer 200 questions from LCB, right? So I think the day-to-day we are keeping up, but there are conversations going on about, depending on what we see, what does this mean for the state? And it's hard to know until we see something, which I hope we see something in May or June, so at least we know what we're working with. And then we can have real, honest, open conversations about that.
John, I try to keep things simple in my mind sometimes. There's really only 4 ways to go when you're in predicaments like this. Tabitha, you mentioned, 300,000-ish recipients that are at jeopardy of losing their health care, and that's what we call the new eligibles, the childless adults. And so that is an eligibility reduction, so that's one of the 4. You eliminate people's health care. The other one is you look at your rate structure. You tell the hospitals you have to take a 5% cut. You have to take a 10% cut. You have to do something. You tell all the providers there's going to be a cut. So eligibility, rate cuts. The third one is utilization. We restrict utilization. We say you used to be able to get 2 visits. You're only going to get 1 visit. You used to get 3 of these. You're going to get 2 of these. So we condense the utilization. And then the fourth factor is go find more money somewhere else.
Well, and you've been through budget cuts before, or budget reductions, as the Director of Health and Human Services. What was that like? How do you make those assessments and decide what to cut and what not to cut?
It's horrible. You just get the team together, and Stacy can talk about this better than I can, but there are things you can't touch. There are mandatory things, mandatory services, mandatory eligibility categories. You're just not allowed to do it under the law. And so you go into the optional list that you have, and it's not a very good list. And so you get your team together, and you sit in a dark room for many hours, and you go down through and try to do the least, what hurts the least, and so it is difficult. In prior administrations, we've been through several rounds of these where, the economy will go bad, or 9/11 happens or something like that, and you just lose your revenue stream in the state, if state or federal or both, and you do what you have to do, but it's a difficult process.
Absolutely. And when we think about those types of cuts, the falling on the hospitals, does that mean that hospitals are going to have to close? Is that sort of worst case scenario?
That's the worst case scenario. My guess is what we would probably see more is some services eliminated, and maybe not all the beds staffed. Although we're having trouble staffing them all right now because of workforce shortages. But that's the concern, and that really impairs access for folks.
One of the things that I wanted to jump back to, Mike, is you were a key part of getting Medicaid expansion in Nevada and making sure that we got more people on this program. How did you convince Governor Brian Sandoval to do that? And why was it so important for us as a state to expand to this critical population?
So we need to go back 12 years if the audience doesn't know. So we stood up the Affordable Care Act, the expansion in January of 2014. So if you look at Medicaid pre-2014, we were a pretty meager program back then. Pre-2014, Nevada had about a little less than 300,000 Medicaid recipients. And that means that we had a 23% uninsured rate. And when we were looking at that, we were the second worst state in the nation. Only Texas was worse than us. So you're talking about a quarter of the population had no access to insurance. So we went through all the scenarios, and one of the good scenarios in the Affordable Care Act was this expansion group eligibility. And it's the childless adult population, and many of us that serve these populations, you know who they are: childless adults, homeless individuals, people not accessing care, a lot of pent-up demand for services, and we just really felt that the time was right to try to opt in. And what was available then was 100% federal financing for 3 years, and then a slide down to 90% financing, which we've talked about today. So it was important to do that, and we saw a rapid uptake after the expansion. We went up to 650,000 recipients and kind of leveled there for several years. And then the pandemic hit and we went to over 900,000. But I want to say this before I end there. When we talk about federal money, one of the things we really looked at in the Sandoval administration was it's not really federal money. It's our taxpayer money going to Washington. And we looked at several reports, Federal Funds Information System, the Rockefeller Institute, and pre-expansion, Nevadans were sending money to Washington and only getting like 80 cents back.
So
we wanted to change that.
And I think that actually addresses the next question that I had for you. Is we've seen that Republicans have sort of said, well, this program was never guaranteed. It was always available for cuts. Why would you sign on to something that may have ended at some point in time? How would you respond to them? Because I think we've heard that from a few Republican leaders, even here in Nevada.
Well, there's always the option that you can opt out. You know, so just when you opt in, many states didn't opt in. Some still have not opted in to the expansion, and so you can opt back out. I mean, and again, that's what's at risk right now for that population, the expansion population.
And that 80 cents that we're getting back, that's kind of your argument, is why would we not get this money back for this population?
Yeah, when I say 80 cents, pre-Affordable Care Act, we'd send $1 to Washington, Nevada taxpayers would. We were only getting 80 cents back. Now I think we're getting $1.14, $1.20.
Yeah, it's a lot of money. Stacey, do you have any thoughts on kind of the role of expansion here in Nevada? I mean, obviously we've cut uninsured rates by a huge percentage. Is there any other benefits that you've seen, and especially because you've worked in other states as well?
Yeah, I mean, in Nevada, this population's about half of the program. A lot of the individuals that are in this bucket have mental illness, substance use disorder, and they're actually getting access to care in a way they weren't before if they were uninsured, and they were ending up in the ER and costing our system more money. So the long-term effect is actually saving us money over time. Also, this is a population that's primarily has been homeless. They're struggling to get on their feet, but we also know a lot of folks are actually working and not getting affordable coverage either. So about 2/3 of our entire population are actually working Nevadans that just don't make enough yet to afford health care, or their employer can't afford to offer them health care.
And I don't want to give you too many hypotheticals, but one that I do have is there are a lot of grant-funded programs here in Nevada that are funded with federal dollars. Are there any worries that some of that's going to get cut? And I know John asked earlier about contingency plans, but are you worried about healthcare access loss?
Yes. I mean, I think it's hard not to. I do think people are serious that something has to change. I mean, healthcare costs with Medicare and Medicaid is over $1.5 trillion. I mean, it's a lot of money. And I think people question, where is all that money going? And that's a fair question. But if you take away the federal funding from states and you don't give them tools to control costs, it's just a cost shift, right? And so I think I'm hopeful that the conversation is about what tools do states need to actually control healthcare spending, because that's where we need to look. And those are the hard conversations that many people, especially politicians, don't want to have. I mean, it's just the reality. But we are the first, including the first red state, Republican state to expand Medicaid. Recently, our governor was the first Republican governor to come out against federal cuts. So I feel very hopeful and actually very proud of our state. It's a Medicaid, I don't want to say bipartisan, because I feel like bipartisan is partisan these days. But I feel like there's a mutual agreement on both sides of the aisle that this program is important to our healthcare system and that we need it. And I think as Nevadans, that's something that should make us have some hope, because I do know that our state will, all of us will fight to make sure that things are not going completely backwards. So that is what I'm hanging on to at this point, and we're waiting to see what's coming.
Let me jump in here, and I hate to be the naysayer here or be the cynic, because I don't know how to play that role. But I don't think if this decision is made that Donald Trump is going to listen to Joe Lombardo or anybody else. I really don't think he cares what they're going to do, what they are going to do, and you can't plan for it. And sure, it's great that the governor wrote a letter saying he's opposed to this, and he should be opposed to it. But I think the kind of the elephant in the room that we haven't talked about yet, and you referred to it obliquely there a little bit, Mike, was this is going to affect the quality of health care in a state that has been derided for decades about the quality of the health care at its current levels. And I saw, Pat, you mentioned something we should talk more about, which is workforce shortages. I've heard for decades about nursing shortages, and then there was the whole crisis way back when, Mike, you remember about doctors leaving Nevada and all the rest of it. So maybe we should talk a little bit about, let's not be hypothetical for a second, and what's the status quo right now? What is the quality of health care? And maybe, Pat, maybe you can talk a little bit about how the workforce shortages that you talked about are affecting that. What specifically are the issues, and how do you fix those absent any of this discussion of a cut in federal funding?
Well, you're exactly right. I mean, workforce is the key to it. I always say a healthcare facility is as good as its worst employee on their worst day, because it is delivering care people to people. And so when you don't have enough people, you start having problems. And so, you know, in the hospitals, we took a survey of our members, and as of January 1st, we had 780 open RN positions. You know, I mean, just imagine if we had those people working, what fantastic.
Can you put that in perspective? Like, what does 780 mean? Out of how many, and how is that affecting things?
Well, what it does is, you know, you'll hear stories of nurses who get a lot of people on a shift. And so what happens is there's a requirement under state law that there are nursing staffing committees in hospitals. So they all get together and put the plan together, and there's no plan that says 1 to 10. But what happens is that during the course of the day, people call off on the various shifts, and that's when the crazy stuff starts to happen. There was someone from Renown who testified at a hearing the other day that each week they get between 400 and 500 call-offs. So you've got to cover that. And you don't know when they're coming. One administrator told me, he said, and the day after the Super Bowl's terrible because no one comes into work. So, you know, but if you had more people, you'd have more people to draw from. And so that would help the situation a lot better. And, you know, the psychiatric facilities in particular in this state aren't able to staff all of their beds. And that's a real problem because we have huge mental health issues in the state. So that hits. So then when you get to the physician side of it, and we're like 46th in the nation, on nurses we're 46th in the nation too, at the bottom. You know, the physicians, nothing can happen in a hospital without a physician's order. So when you don't have the physicians, you're just not going to be able to take care of people like you normally would. So it becomes a huge problem. But as Stacy was just mentioning, you know, the emergency rooms now in this state are just crazy because they're primary care and mental health facilities, and that is absolutely not the role. When you go to an emergency room, you should have an acute care condition. But what's happening is when there's a problem with someone having a mental health breakdown, first responders bring them to the emergency room, and then they can leave. And so we're housing them there, and believe me, an emergency room where there's tons of noise and beepers going off and codes being called and all the chaos is not where you put a person to de-escalate from a mental health situation. Terrible place for them to be. And then the other side of that is we've got all these people coming into the emergency rooms to receive primary care because there aren't physicians in the community to just deliver the basics. You know, 1/3 of the emergency room admissions in Nevada are Medicaid, and they only represent 20% of the population. So it just can goes throughout the system, and we really need to address
Tabitha, I
it.
want you to jump back in, but I have
No, go for it.
I have a question for you. Like, who invited this guy? He's depressing me.
Well, it's interesting because we did some behavioral health research as part of a series that we worked on where it showed there were 9 licensed psychologists in rural Nevada. That's all of rural Nevada. And when you think about people that are going through a mental health crisis, you're absolutely right. We are going to deliver them to the emergency room because that's the place for them to go. And where I kind of want to take this conversation is we know there's a shortage. We know that's really bad. How do we fix it? How do we think about addressing it? Is it just putting more money into residencies, like funding into programs? Where do you see the solutions for that?
Well, I think that's one for the physicians. But, you know, I can't understand why our nursing schools don't produce more nurses. I mean, we turn people away every year who are qualified. So if you have a huge shortage, why would you be turning away qualified people from nursing schools? And so we need to build that up and get that going. In 2030, we're projected to be in the top 5 states in the country with the biggest shortage of nurses. And so that's very scary because we're all getting older and we're going to need these folks even more. But, you know, there's not one answer, but I'm going to go back to Medicaid because here's what happens is one of the reasons historically we don't have it, and this has nothing to do with Stacy, but providers get paid very little by Medicaid, but yet they're a huge part of the patient population. So, you know, if you're sitting there and you're a doctor, you came out of med school and you've got the average now is $230,000 of debt coming out of medical school, and you still have your undergraduate debt, you're going to look to see where you can make a living to pay that off. And Nevada's not the most attractive place.
I'm going to let Stacy
I'm going to
jump
jump in there, Pat. I don't mean to correct you, but Kaiser Family Foundation has a study showing Nevada is in the top 10 for paying physician rates, believe it or not. The challenge is how many people are at that rate, right? So it's not necessarily above Medicare commercial rate, it's close to Medicare. Hospitals, you're right, but we are supplementing those payments. I'm not going to say Nevada's perfect, and Medicaid as a taxpayer-funded program, I don't think can ever pay commercial rates. We can't afford it. I mean, right now we're barely, some of them are at Medicare above, and Mike and I have had this conversation. His doctors are always challenging my quote on that, but the reality is healthcare is expensive, and nothing is ever enough, and that's the hard conversation. And I do agree reimbursement rates matter. I think how we pay, like we should be doing bonus payments for people who are serving rural populations or the harder to serve population. And also just thinking through, like for us in Medicaid, just getting more physicians and more providers doesn't solve the problem. Are they going to take Medicaid? Are they going to step and help serve the hardest and the most challenging patients sometimes that we have in Medicaid? We have a lot of serious mental illness, a lot of significant need. And I think from Nevada, you know, we don't want to require people to do more than they have to, but that's the question I have is how do we get a workforce that not only shows up in Nevada and wants to be in Nevada, but actually wants to serve the Medicaid population too. So I think that's our challenge. Sorry to jump in, Pat.
No, that's fine.
Yeah.
And I think we can't lose track of, you know, we've been working at graduate medical education. You know, the Office of Science, Innovation, and Technology has been the lead sled dog on that for 10 years, and I think the plan is to move that into Medicaid, and that's the right way to go because you can leverage federal bucks and grow that. And so we have to do more of that. We have to look at more of the loan repayment programs, particularly getting, I think, healthcare providers into rural Nevada with the loan repayment programs. So these things are happening. They're just not funded well enough to be where we need to be. So one more time, it goes to my earlier comment. I know healthcare is about healthcare, but healthcare does not happen without funding.
Well, and one of the providers that I spoke to mentioned high housing costs, right? And when you're making a salary where buying a house is unaffordable, you're going to look at places that are more affordable. Maybe it's Ohio, maybe it's somewhere else. Is that something that you think about at all when we're having these kinds of discussions?
Yes.
Stacy, go ahead.
Yeah, sorry. So there have been some discussions over the interim with a variety of groups, and Pat, I think you were at one of these tables. But looking at some of the new funding that the governor and the legislature are considering to put into workforce, like doing a housing stipend, especially if folks, we need them to be in an underserved area. But the economy really does play a big impact on whether or not people want to come and live in Nevada. And the price of housing, as we all know, is very high. But go ahead, Pat.
Well, I just say in rural areas, if you have to rent, there's not a lot of great rental properties too. I mean, that's another challenge.
Right, providing that workforce housing. Now, the other piece of this, and we've talked a lot about the provider side, but I want to move a little bit more into the affordability for the average person. We've seen a number of discussions at the state legislature, out in the public sphere as well, about how healthcare is just too expensive. Now, there's various proposals going through the legislature, but how do we kind of think about reducing the costs for the everyday person, whether they're on Medicaid, whether they're on a private insurance plan? Because it just seems like you go to the hospital and you spend $800 even if you have a decent insurance plan.
So, well, I'll jump in here. You know, it amazes me as I sit through these legislative committees that so many people get up and talk about the huge cost of health care. And they're always talking about a bill that costs more money to the healthcare system. And it's like, you know, all these things are really nice, but you can't have every bill costing, you know, millions more to take care of. So, I mean, that's one of the things that we have to really prioritize. But I'll tell you one of the areas that it just amazes me no one gets into, and that is the administrative costs related to healthcare. We're like double the rest of the world on administrative costs. And you sit there and you wonder why. I mean, they now calculate that physicians spend 15.6 hours a week on administrative work. Well, if you have a shortage of physicians, you should try to figure out how to get that down a little bit so that they could actually be taking care of patients as opposed to doing paperwork all the time. And that's their number one frustration too when you talk to them about it. And you know, we just need to really sit down and say, is all of this stuff really worth it? Does it add that much value? And I think that's a great area to start saving some money.
Do you two agree, or are there other places?
I agree 100% with Pat. We've had conversations about this, that if you look into the Nevada Revised Statutes, there's a long list of programs and services that Medicaid has to provide, and every year that grows. Legislators pass additional bills and more things are put into the basket of healthcare. And I think we've kind of lost our way when it comes to some of the basic things that aren't working as well as they should. Primary care access, behavioral health, early behavioral health access, good transportation. Low-income people can't get to and from timely to their health care. I think we have to focus more on those basics and less, and again, I don't want to sound like these things on the fringe are not important, but if the core things in the middle are not working well, they're just not working well.
I definitely agree with you guys, but I'm just going to say something controversial for a second. We have to have a conversation about overhead and profit in healthcare. We have to have that conversation or we can't afford to keep up. It's just reality. It's like being on a train that you see it going over the cliff. That's what it's like working in Medicaid and knowing healthcare costs are going up. We can't keep up with it. And everybody wants more. Everybody keeps adding on. But we have to start talking about, we have and there's nothing against having for-profit hospitals or providers in our state, but we do have some of the fastest growing healthcare costs, and we have the greatest number of for-profits in healthcare in the country. So I think we have to have some honest conversations about who is supposed to pay for that, right? And I think that's the hard conversation, especially as seniors and our baby boomers are growing older. Believe it or not, Medicaid pays for long-term care, right? That's the dirty secret of Medicare. It's not going to pay for all of that. So it's the states that are paying for it. So anyways, I agree, the overhead, the prior authorizations. I'm married to a doctor who tells me every night how many hours he spent on prior authorizations. I totally get it, but I think there's this other overlay of overhead that we need to look at too. And it's not just providers, it's health plans, it's everyone that's involved in healthcare. Yeah.
I guess I want to add one thing. It sounds like sometimes that the healthcare providers are this mean group of people that just are in profit. But I'm going to tell you, there's at least two groups that have worked very hard, the hospitals and skilled nursing. You know, you need a basic rate to be able to provide the care that you need. And Medicaid can't often do that because there's just not, again, I keep hitting the financing button. So I'm going to just give you an example. Skilled nursing. There was a law passed last session that we need to get to a $275 a day rate. The state only guarantees $159. That's a big gap. That's only like 60% of where we need to be. So the providers have stepped up, the counties have stepped up, and they're putting money into the system so we can match federal dollars and boost that rate. It's got to get to a rate that's affordable to provide the care, or the beds aren't going to be there. The same thing has happened this last year with the hospitals doing that, taxing themselves, a 6% tax, matching federal dollars, and you can boost the rates. And so it's a complex system, but if there's not a basic rate, healthcare can't be provided.
Is it too complex, Mike?
It's too complex.
I mean, you've been in this for 45 years. Why haven't you fixed it? No, but seriously, you're king for a day. What do you do?
Well, Stacy and I are working on some ideas, as others are. I think it is about some simplification. You know, it's really, we've added on and added on and added on to the point where it's got so complex that, you know, we've flow-charted things galore trying to figure out, you know, how could we make it simpler? And I think it really has to come back to find the basic rate that makes things work and find the simplest financing mechanism to do that. Again, I don't want to beat up skilled nursing again here, but there's like 12 or 13 rates that you have to go through to figure out, and they all have different match and funding rates and who puts in the dollars, and it is complex. And everybody just thinks if you go to a nursing facility, Medicaid pays a certain thing. It doesn't work that way.
But okay, so I mean, if it was just up to you and Stacy, I'd feel good. You guys can fix everything. But there's all these interlocking players. There's hospitals. There's insurance companies. There's doctors, and not all of their interests are necessarily all aligned. And so, rather than making this sound hopelessly complex, and you know, I think it's facile to say that, you know, Pat left his black hat at home, that it's the hospitals that are all to blame, or that it's government waste, you know, that maybe we can get our friend who owns the Gigafactory up and to come and fix this. But seriously, how do you get all of these players together and realize that they have to work together to fix this? Is that impossible? Because if you don't do that, you and Stacy can come up with some great reforms, and maybe Pat can come up with some ideas for the workforce shortages. But this whole prior authorization, you're going to get me going now, since you know, I have to deal with that. And they try to get around it, and it takes time, and it's crazy. And so, how do you get naturally competing forces together to solve this? Why do you think we brought you here? Solve it.
So let me tell you something, that if you really want to look at a model that is just really interesting, it's Mark Cuban and Cost Plus Drugs. Here's a guy who's taken his wealth and gone and said, I'm purposely going to disrupt an industry. And it's pretty amazing, some of the stuff that he's starting to accomplish. And I think we've got to have other disruptors, because you're right, everybody's makes a little bit of money out of every part of the system. And it's very hard for anybody to say, I don't want to make any more money, you know? And so it's so difficult. Even when we sit down and have meetings and talk about, well, what if we did this? Someone comes up with, well, this regulation, you know, won't allow you to do this, or you can't do that, and, you know, the contracts we have. It's just so unbelievably complex.
And one of the solutions that you all thought of actually in 2023 to address some of these costs and bringing more money into the state was the provider tax. And that was essentially that hospitals voted to tax themselves, which is very rare. And then a portion of that funding would be matched by the federal government, come back to the state. I know that money has been sent out. There's a portion of the funds that we got back from the federal government, is my understanding. What's the status of that? Are we worried about not having that money come back to Nevada with everything that's going on at the federal government level?
Do you want me to take it, or you want to?
I can take it, it's fine. You can add some commentary to help me, Pat. So last state fiscal year, we brought in we paid out a little over $1 billion to hospitals, but a net gain of about 700 and something million in payments back to them. And then we have been in a holding pattern since the new administration came on board at the federal level. We haven't gotten the approval that we need every year to pay out one portion of the payment, which is the biggest portion for this next year, which is about $800 million. So I will say all of us had a lot of nerves and weren't sleeping very many nights worrying about $200 million, and then now it was $400 million now that we're in quarter two. But there's been a lot of conversation. Our governor's office has been pushing really hard. We were able to pay out the first quarter. I think what worries me is how long everything takes. I do think we'll get approval eventually, but I'm wondering how sustainable these delays are for our hospitals and the cash flow. So we're looking at some other ideas around, do we just build the money into the rate, and are there other things that we can do differently? But again, that makes healthcare complex. Why is it so hard? I don't know. I ask that that question myself all the time. It shouldn't be so hard. But the hospitals are putting in a lot of money, and then we're drawing back down that share. Now, if we do lose the adult expansion funding, which is that 90%, it significantly changes the game, and that provider tax may not be the same program, and it may not be viable for the hospitals, or maybe more losers, right? Every provider tax, you're gonna have winners and losers. We have very few losers in our hospital tax program, and that's why it works really well.
And it's not just hospitals that are affected by that, right? We also know that a portion of that funding is going to children's behavioral health and some of the services that are required. I don't know how much folks know about this, but a couple of years ago, Nevada was cited by the Department of Justice as having shipping children out of state because we didn't have services in home communities. You had children who were institutionalized. We got in quite a bit of trouble. We eventually reached a settlement with the Department of Justice, and part of that settlement was the state committing to overhaul the children's behavioral health care system here in Nevada, some of which is dependent on that funding, is my understanding of it. Is that something you're worried about losing, or what happens to the children if we don't have that money?
Yeah, I mean, any of the talks around changing the maximum tax rate that we can tax the hospitals would impact it. So state law, last year, the governor and legislature all agreed that at least 15% of that revenue should go to behavioral health care through Medicaid. We have taken that funding, which is about $70 million this last biennium, and just started to invest in community services for children, youth, and young adults. And thanks to the hospitals, honestly, that it was a partnership. No one was really fighting it, which was really great. I think we're the only state that really has a dedicated funding stream to children's behavioral health. So that I am worried about it. If they do change the tax rate, that means we get to collect less for those services, and we'd have to adjust how we're funding those going forward.
Yeah, that's the really neat thing about this is, for once we had a plan to really address mental health services for children, and it goes to adults, and now all of a sudden we have an interruption in it. And Stacy's done a great job of outlining and really a thoughtful plan to do it, and now we're on hold, basically.
It's making me tired, yes. Yeah.
Does that mean that we won't be able to stand up some of these services? Is it kind of a wait and see situation? We have 5 years, I know, to sort of fulfill that settlement agreement.
Yeah. No, we're moving forward. I mean, we have to. We have the DOJ I don't know how many, I think my team's meeting now weekly is still with them. And I met with them for over 2 years. That was enough for me. Enough attorneys, and I'm an attorney. But we are moving forward on standing up a lot of the services. The issue right now is we have a lot of federal approvals that we're waiting on. Again, that federal process sometimes can delay all of our work for years at the state level, which has been a real challenge. I think the one thing that, besides the changes to the tax rate that could happen, the thing I worry about is the workforce, just getting the providers not only to be in the behavioral health space, but want to take some of these more challenging cases.
Mike, yeah.
One thing I just want to jump in here. When John asked the question, how do we make things simpler? I'm going to tell you right now, a lot of it is simplifying the federal rules process. As Stacy just talked about, every time she wants to make a change, it's pretty easy to run to the Interim Finance Committee or to the Board of Examiners at the state, because they meet monthly or every other month, and you can get things approved pretty quickly. When she sends a state plan in, it might take 6 months. It might take a year to get the approval from the federal government. Then if it's not a state plan issue, it's a preprint issue for what we call state-directed payments through the managed care organizations. Those take months to get through. It just puts you in limbo land that you have a plan that we've talked about. We have the money from the hospitals. You can move forward on children's behavioral health, and then everything is pending through state plan amendments or preprints, that the federal government moves slow, and they need to find a way to speed up, whether it's state plans, waivers, or preprints.
It'd be nice if they just had a deadline
Yeah.
that they had to meet, after 60
What
days after
happens,
receiving.
you submit something to the federal government, and all they have to do is ask her one question, and it stops the clock. They have 90 days to do something. They ask her one question, stops the clock starts over again. It's like playing, what do they call it, speed checkers or whatever.
Right.
It's a tough process. It takes months to years.
And with that same kind of process, a lot of the problems too with our children's behavioral health care system and kind of our healthcare system in general, as we noted, was the provider shortage. Is any of the programming that's happening or the plans to attract providers here or increase the number of psychologists? I mean, we talked to families who were traveling from Elko all the way to Twin Falls to get children's behavioral therapy, right? And I couldn't imagine having to drive that many hours every single week,
Yeah, no, it's not, it's not sustainable for families. And I think there are a couple things that we're working on right now. I would say nothing, again, is moving as fast as we need it. It's a crisis. And what we are looking at, there are a variety of training programs, apprenticeships programs for behavioral health. I know the director's office has been putting together a variety of programs with UNLV and UNR, but I will say we're also looking at getting a specialized managed care plan to come out and invest in the network. And part of that will require them to do community reinvestment dollars to ensure that we have providers. But a big issue too is that we don't cover some of the services too. So if you don't cover the services, the providers aren't going to come either. So it's really trying to get everything up and going. But all this is happening at the same time we have the session and we have the federal stuff. So I think sometimes it's hard to keep the momentum because we do have about 300 people. But believe it or not, that's not very many people when it comes to running an insurance company for 800,000 people.
I wonder, Tabs, it might be worth asking each of you, because you mentioned several times now that there's a legislative session going on. And by the way, just by point of reference, I've known Mike Wilden a long time, and I've seen him in the legislative building many times. Not once did he ever look happy in the legislative building.
Not true.
No, come on. But seriously, so each of you name, if you could prioritize things that the legislature could have an impact on, not the federal government, the state legislature, that they could pass this time to help this situation, what would they be? Go ahead and start.
I would just say we've got to focus on the basics. I mean, you can't build a great healthcare infrastructure if you don't have the workforce and the people and everything. We just got to really focus and spend some money on the basics.
What does that mean?
That means nursing programs. That means they're working on GME. See a lot of hope there, but that's so expensive. A GME program for a resident's like $200,000 a year. And so, we need lots of doctors, and we don't have the money to fund that. But, just going through and, looking at how can we deliver primary care better in the rural areas, how can we deliver behavioral health. I was all excited because for once we had money to do behavioral health throughout the state. And we thought, okay, this is really, and that's one of the reasons hospitals didn't fight it, because we understand there's a big thing. And we said, okay, you can take 15% and do this. So it was very exciting, but now who knows where we are.
I agree with the basics. Certainly workforce is the biggest piece. We've got to get the workforce solution figured out. And again, it's graduate medical education, it's loan repayment, it's whatever we have to do to get the workforce here, docs, nurses, and other groups. But then again, in the basics, I think, like I said earlier, I think we have to, the fringes are important, but if we don't work on primary care and behavioral health, top of the list, both children and adult. And when I say work on behavioral health, the DOJ study says it all needs to happen in the community kind of thing when you read the report. There's really an array of things that are needed. Every kid cannot be served in the community. Some need residential, hospitalization, whatever. The system needs to be there. you hear every day where we don't have a bed for somebody. And so the behavioral health system needs a total overhaul.
Yeah, I mean, I would agree with all of that. And maybe I'm a little biased, but I just want them to pass our budget and everything we ask for. I mean, I think there are a couple bills moving around single PBM, which is a pharmacy benefit manager, and there's also prior authorization, simplification bills. I think all of those are helpful, but I also just want to be mindful of the bandwidth that we all have to implement these major reforms. And I feel like sometimes we get our breath after implementing the huge hospital tax program, and now there's going to be a whole nother reform to implement. We haven't quite finished making sure those other implementations are fully done. So I just more or less worry about bandwidth, but I do think some of those efforts are meaningful and can help the system over time.
I'm going to throw this back to Tabitha in a second, but Stacy, since you mentioned them, I think most laymen, most people you ask on the street say, do you know what a pharmacy benefit manager is? They have no clue what you're talking about.
Yeah, I don't either.
Exactly.
All I know is I need them, and they're this middleman that's like a
But
black
they're a huge
box.
part of the healthcare system.
Yeah, they make a lot of money.
So you're, what legislative initiatives should be passed that would, do they need to be better regulated? Do they need to be capped? What needs to happen?
A couple things. So the hard part about pharmacies, it's federally regulated. But as a state, this is my favorite thing, is purchasing healthcare, right? And that's something we do in Medicaid, and we purchase our pharmacy benefit. What we have on what we call our fee-for-service side, which is where we pay providers directly for certain populations, we have our own PBM where we design it, we know what money's going in and out, we actually can maximize rebates and savings for the state. On the MCO side, there's 4 different ones, actually 5 if you count the dental. So you have all these different PBMs that we're not really, there's no way we can see in to know, are we getting the best rebate? Are we maximizing and purchasing pharmacy benefits for the best deal? So there are bills out there, including the governor's budget bill, which includes the Nevada Health Authority, which would create a single PBM across Medicaid and then also eventually across our public employee benefit plan. Because that is an area where we know that drugs and pharmacy costs are really making the public employee plan unaffordable. So if we can get a hand on that, make sure we have the expertise on team, we need vendors. Let me tell you, we can't do this ourselves. But if we can get a handle on that, I do think we can start to bend some of that cost curve. But it is all about how we purchase healthcare in this state, and I'll stop there. But yeah, I don't really know what a PBM does either, so that's why I want my own, so I can see what's really behind the box. Yeah.
I think it's important for the audience to know, we've talked about the multiple PBMs and the multiple prior authorizations, but 74% of Medicaid recipients are in a managed care organization. And so that's a different whole process than the fee-for-service population that Stacy mentioned. So 3/4 of Medicaid recipients are in one of the 4, 5 if you include dental, managed care organizations in separate processes, and 1/4 are in fee-for-service, mostly the elderly, blind, and disabled.
And what does that actual difference mean for somebody? What's kind of the differentiating factors there?
So eligibility-wise, again, there's groups of people, moms, children, the childless adults that we talked about, the expansion population. They all go into managed care. They pick a managed care organization. If they don't pick one, they get assigned to one. And Stacy's folks pay them a per member per month fixed rate to provide their care. Fee-for-service, child welfare kids, and the aged, blind, and disabled, they're in fee-for-service. They don't have care management, if you will, through a managed care organization, and so they just go see their healthcare providers and get paid fee-for-service for whatever healthcare they get.
Yeah. And Stacey, go ahead.
No, I was just going to add to that. If it's working right, the people in managed care should have a network of providers that they can see. And the sad thing about fee-for-service, which I'm not saying all fee-for-service is bad, but I do think we fail people because we do not guarantee or have to guarantee that there's a network. And we're not building it because we don't have the capacity to as a state. Managed care has a network that they have to meet. They have certain quality standards they have to keep up with. They also have to do case management, intensive care coordination. If everyone's doing what they're supposed to be doing, it should be a better system for individuals in managed care.
You talked about the challenges in rural Nevada, people going to Twin Falls. Stacy just approved 2 new managed care.
I did? Oh, yes.
Yes, you did.
I was like, what?
Yeah,
Yep.
just did a request for
Statewide.
proposal, and statewide managed care will go statewide for the first time in Nevada.
And that'll help people kind of stay on a uniform plan
Yes.
within a network and coordinated services.
Because the managed care organizations are required to build a network.
Absolutely. And you mentioned the Nevada Health Authority, and we've got to talk about it because that was a massive proposal that Governor Joe Lombardo made in his State of the State address. Is that just adding another thing for us to change as we're talking about all these changes that we're trying to enact? How will it actually help our state?
Yeah, I mean, yes, it is change, but I think it's taking a very massive, agency, which is DHHS, which is our Health and Human Services agency, and trying to make it organized in a way that's manageable and seamless to people, and as well as the people trying to run these programs. Right now, you've got a provider system as DHHS. It's a payer of healthcare. It's also kind of an entry door to benefits and system, and it's also a regulator. There are inherent conflicts of interest in that. Trying to be a regulator, regulating yourself as a provider is also one of those things. So I think the goal here is to really divide that back up and look at DHHS from the perspective of this is the DHS side, which is providing human services and healthcare and other benefits directly. And people should be able to navigate that. And then the healthcare side, where we're trying to purchase healthcare, improve access, working on workforce, working on coverage, working on purchasing, right? Getting that best deal for everyone. That is going to be its own space, which is called the Nevada Health Authority. A couple other states have taken this approach. I think every state has their own flavor to it. I think the design of ours is really to try to maximize those resources across Medicaid, the public employee plan, and the exchange, so that way we're all working together in the same stride, right? Sometimes we're in our own silos. That's just natural when you're your own agencies.
Mike, obviously you worked under the Department of Health and Human Services for a long time. Is this proposal kind of outlandish? Is it wild? Is it so new that you're worried about it, or do you think it's a good idea?
I think it's a good idea. I mean, I'm supportive. I particularly like the component, well, some of the things she's talked about there, but I like the integration between Medicaid and the exchange. We haven't really talked about the exchange, but as part of the expansion, so I try to make things easy in my mind. People below roughly 200% of poverty can get Medicaid. You're above 200%, but going up, you can buy an insurance product on the exchange. There needs to be integration between there and quick handoffs and easy handoffs and a single eligibility process where people can, if I went in this door and I wasn't eligible here, I want to get my health coverage here and vice versa. So I like that component, and I like the looking at every place you can save dollars, whether it's pharmacy or purchasing things and things like that. So the more volume you have, the more opportunity you have for savings.
Are we required, if this passes, to call you Queen Stacy, or how is Your Majesty? How is this going to work?
Just Stacy. Yeah. Someone did ask that one day, and but no, just Stacy.
So, Tabitha, we really should try to wrap this
Yeah,
up.
I agree.
So I'm going to let you wrap it up with the final question.
So I think that the final question for me, and we've talked about a lot of not so happy things tonight, but kind of what's keeping you up at night, and what are your maybe one takeaway that you want the audience?
Way to end, Tabitha.
Sorry. but what's one thing that's keeping you up at night, and what's one takeaway that you might want the audience to have before they leave? Whoever wants to jump at that one first.
The legislature keeps me up at night. I have not slept for the last 2
Join the
months.
club.
You
Join
and
the
me
club,
both.
man.
And I'm not kidding. I have not slept. It's just, there's just so many proposals, and everybody wants to do the right thing. So I understand that, but I don't think everybody appreciates how everything interconnects in healthcare, and everything does interconnect. And when you push in one area, something happens in the other area, and that's what worries me, is that we'll get some things that are going to not be helpful and very expensive to the system.
Financing keeps me up at night. You knew that would be the answer for me. I mean, healthcare is healthcare, but financing keeps me up at night. We've talked about the taxes and the potential reductions there. We're coming off what we call the ARPA cliff. A lot of things got funded with ARPA dollars that are going away in a year here or so. There's, the Economic Forum has a specific forecast that the legislature has to fit within. So there's just a lot of economic upheaval right now between, again, ARPA, Economic Forum, and some of our revenue streams that we've worked hard to put in place that are in jeopardy.
Yeah, I think on that same note, I think we've all been working really hard in healthcare to make things better and to try to maximize what we have, including provider taxes and everything we've been doing. And I think just what keeps me up is like moving backwards, like all of the work we've been trying to do, and like how do we keep the momentum, even if things maybe don't go the way we want them to, and how do we move forward? To leave people with, I think, trying to think of something positive, Tabitha, after such a very, very depressing conversation. No, I'm kidding. I think something to leave folks on is that, you know, we are in Nevada, we are at the bottom, unfortunately, in most outcomes, right? But I do think we have the ability to move forward. I do believe that. I think Nevada is a special place. I've worked in other states. I think people do care about healthcare. I think it can be bipartisan, or whatever we're going to call that word, mutual, if we can. And I think that Nevada, you know, even though we don't have a lot of revenue, we make the most out of what we have, and I think that's something to be proud of. So I'm excited to see where we're going to go, even though we're going to face some crisis. And what's the saying? When there's a crisis, there's an opportunity. There's some, you know, I do think there's something coming out of if there is a crisis in funding, I do think something good will come out of that somehow. It has to.
There are a lot of really good people who want to solve the problem, and that's the real positive.
And I have to say, in wrapping this all up, I don't think it's a depressing discussion at all. I really don't. No, in the sense that I hope this kind of elevated discussion, which I really appreciate all of you taking the time to have tonight, energizes people out here and others to say, you know, this is a very difficult, complex problem, but that there are great people like the folks up here who want to try to solve it. And it's not going to happen in one legislative session. It's not going to happen in 6 months. But that some people, and I think you're right, there are a lot of good people who want to help solve it. Some of them are in this audience tonight, I'm sure. So I just want to say thank you on behalf of the Independent for your willingness to come and have this kind of conversation. And was I right or wrong about Tabitha for doing just a great job and getting up to speed on these issues? So thank you, Tabitha, thank you, panelists, and thank you for coming and listening to this for an hour. Thanks so much for coming.
Thank you.